pleasure because as you all know, some of we have been part of this workshop before also, and this is a extremely good platform for sharing the interesting cases on to the larger group of audience, and thereby gaining the insights and thereby fostering the way to the learning, discussion, and exchange of knowledge. So let me first introduce our course director for today, Dr. Sadananda D, who is MBBS MD and DM Neurology, and is a senior consultant neurologist and stroke specialist at Apollo Multispeciality Hospital, Kolkata. Sir has completed his DM Neurology from IPJ-MER&R in 2013 and has also done his stroke fellowship from the University of from Canada in 2016. Sir has got multiple national and international publications. Sir has got multiple national and international publication and has also presented papers at various national and international conferences as well. He has also actively participated in multi-center randomized trials during fellowship, and he has been a recipient of Tribal Grant for paper presentation in 2018, and also a recipient of Young Neurologist Award from WSO in 2014 as well. He's actively involved in acute. Sorry, yes. Any issue?
No, Dr. Shutal,
should I continue? Yeah, thank you. Yeah. So it is actively involved in acute stroke management and also is involved in raising the awareness of acute stroke management at state level as well. He's enrolled in Apollo Multispeciality Hospital from past 4 years and is worked as an in charge in acute stroke management in Kolkata till 2019. We are very honored to have you, sir, and we look forward for your guidance in this workshop.
I would now request Dr. Sadanand Ray to give a short introduction of the rest of our faculty members.
Sure. Thank you, Dr. Sutal, for kind introduction. So, yes, our course moderator will be Dr. Biswajit Paul, who is consultant intervention neurologist at Manipal Hospital, Kolkata. So he has more than 15 years of experience in diagnosing and treating stroke and other neurological disorder, extensive experience in interventional and endovascular procedures. He has numerous publications in national and international journal. He is member of different associations, including Indian Stroke Association, World Stroke Organization, and Society of Neurovascular Intervention. He is also member of European Stroke Organization. So our next moderator is, I think you can put the introduction slide.
Dr. Shrutal, you can share the screen, please.
I'm sharing the screen.
It has got, it is not appearing now.
I think there is an error in the screen. So if Dr. Sadanand, you could already introduce.
Never mind. You can just call me Dr. Sadanand Des Jr. That's fine. That should be good enough.
No.
Yeah. Is my screen visible?
Yeah, it's visible.
Yeah.
Yeah. So Dr. Vaibhav Seth is our speaker today, and he is currently consultant neurologist at Manipal Hospital, Salt Lake and Broadway, with prior experience at ILS and Apollo Hospital. So he teaches nationwide as a specialized neurology faculty member, mentoring aspiring for the NEET, SS and NEET PG both. Oh, congratulations. So I didn't know that. And he specialization in movement disorders, headache, neuroimmunology, and the independent administration of therapeutic Botox. He is author of 7 journal publication on COVID neurology, autoimmune encephalitis, and myasthenia gravis. He won first prize at the World Neuroscience Summit in 2022 and undergoes advanced training with the World Headache Society. Our can you put the next? Yeah. So Arindam Ghosh is our today's moderator. He is my very good friend and very dynamic person, I will say. So he actually is attached to Narayana Health mainly, and he does a lot of practice in other centers also. He has multiple publications. So 16 chapters as author, co-author in textbooks, CME books, and monographs, 6 publications in index journal. His keen interest in movement disorder, headache, neuroimmunology. So he got Dr. MGR Gold Medal for the best outgoing student in the DM Neurology 2018. Sri Ramachandra University, Chennai National Best Paper Award, Epicon 2012. Co-investigator in 6 FDA-approved research trial and organizing Joint Secretary, ECTRIMS 2019, Kolkata Neurology Update 2020-24. So next, I think Dr. Jaideep is left. So
Yeah, just give me a minute. Just give me a minute, please.
Dr. Shutal, all you are, I guess you are on mute.
Sorry. There's some technical glitch actually. Yeah. Yeah. Thanks for that. I was not able to share. Yeah, computer screen was visible.
No, the screen is still not visible.
Yeah, I think the same issue lies with her. That's where I was able to share my
Signesh,
screen.
can you look into?
Yes.
Yeah.
yes.
Yes,
So-
computer screen
yes.
visible now.
Yes. So Dr. Jaideep Biswas is our today's speaker. He is a renowned neurologist in Kolkata. He is currently working as a consultant neurologist at Ruby General Hospital. He has done MBBS from Arjikar, postgraduate in medicine from Bangalore, and postdoctoral in neurology from National Neuroscience Center. In his rich career, he has done many research work, conducted many workshops. He has attended as a speaker in many national and international conferences. I welcome all the moderators and speakers, and I think we should now start. So our first is who is going to present case first?
I think Dr. Biswas can go first.
Okay. Jaideep, you can go ahead with your case.
Thank you. Thank you, Dr. Sadananda, for the kind introduction. A very good evening to all of you, all my seniors and colleagues, and to all the delegates. So can I ask the team to share my slides? So today I will just go through a few interesting case scenarios of stroke thrombolysis. Please proceed forward. So, as you know, as a clinician, we are always doing some balancing acts, because most of the times there may be a dilemma about which way we will go. In stroke thrombolysis also, sometimes we are facing a dilemma, because if we go with the thrombolysis, it is significantly reduces the long-term motor and speech disability, but on the other hand, it remains highly bounded by severe risk safety boundaries. Because in intravenous thrombolysis, systemic thrombolysis, you should remember that it sustains a 3.75 odds ratio increase for symptomatic intracranial hemorrhage. So in order to solve this dilemma, we should proceed with an advanced solution tool. In case of the modern triage algorithms, they bypass the strict chronologic restrictions by using this 4P, stands for parenchyma, pipe, perfusion, and penumbra. Parenchyma we can see by a non-costed contrast CT scan to see if there is any, rule out any hemorrhage. Pipes, we should proceed with CT angiography to identify any large vessel occlusion. And perfusion and penumbra, for this we should proceed with the perfusion study to find the viable brain tissue at risk. So these 4P algorithms is our best defense against the strict chronologic window limits. And finding the penumbral mismatch allows safe treatment of patients who would otherwise be left disabled. Let's go to the next slide. So this is our first case scenario. The highlight of the case is that the onset was unknown. The 64-year-old male patient with chronic hypertension and poorly controlled type 2 diabetes. He was found by his wife at 7 a.m. in the morning with a severe right-sided hemiparesis and aphasia. The last known well was at the 10 p.m. last night when he was going to sleep. Now on examination, the NIHS score was 14 and the reports showed HbA1c 8.8 and the emergency department blood pressure was 165 by 95 millimeters. So here the main problem is of chronology because there is a gap of 9 hours which pushes beyond the standard regulatory 4.5 hour time of giving thrombolysis. So now the question is this patient completely excluded from the systemic thrombolysis option? The point you should remember is that the chronological time is a poor proxy for the ischemic core progression in case of slowly expanding infarcts with good collateral flow. Go to the next slide. So what is the option in this patient? We should proceed with a MRI scan of the brain stroke protocol. And we should look for the DWI flare mismatch. This technique serves as a proxy physiological clock assessing the presence of intracellular water movement change.
Dr. Jaydeep is not audible.
Stroke conscious.
Yeah.
Am I audible?
Yeah, so your voice is cracking. So
Oh.
Okay, continue. So now we can hear again.
So what is the mechanism of this diffusion flare mismatch? The DWI turns positive within minutes of cellular swelling due to the cytotoxic edema, but the flare takes 4.5 hours to turn hyperintense due to the vasogenic edema. So therefore, the DWI positive and the flare negative mismatch, it confirms that the stroke is in the early thrombolysis window. Let's go to the next slide. So in this patient, our clinical decision was to administer IV thrombolysis immediately and monitor for the neurological changes. Because this patient has salvageable tissue and postponing thrombolysis based solely on the timing of the last known well in the presence of positive MRI mismatch would lead to suboptimal management. Now, what is the landmark trial evidence? In the Wake Up trial, it was shown that the thrombolysis guided by diffusion flare mismatch in unknown onset stroke, they led to significantly improved outcome at 90 days, MRS 0 to 1 versus placebo. And the symptomatic bleeding rates, they remain same or equivalent between both the groups. So this is the yes, this one.
Go to the previous slide. I think you moved one slide. Yeah, let's start this here.
Yes, yes. So this is the second case scenario, and the highlight is of fluctuating deficit. The second patient is a 45-year-old male and is accountant by profession. And due to her profession, she is highly dependent on the fine motor skills and calculation. She arrives at the emergency 2 hours after sudden clumsiness in her right hand and mild fluctuating word finding issues. On examination, the NHS score is 2, 1 for hand drift and 1 for dysarthria. And the symptoms seem to slightly improve during the examination. So in this case, there is a clinical trap, because if we withhold thrombolysis by categorizing this presentation as a minor rapidly improving stroke only based on the low NHS score, the point we should consider here is that is the low NHS score truly benign for this specific patient? Because if you do not thrombolize this patient and she lives with a clumsy hand, it will be impossible for her to work as an accountant. So the clinical distinction between disabling and non-disabling minor stroke deficits is very important in this patient. Next slide. We should individualize the deficits of the patient, because the loss of fine motor control in a dominant hand is catastrophic for this patient who is an accountant. Similarly, a minor visual field cut may end a professional career of a driver. So the important thing is early detection, because over 30% of patients with minor strokes who do not receive thrombolysis, they experience early worsening due to the propagation of the clot. So what should we do? We should proceed with the advanced diagnostic step such as CT angiography. In this patient, the CT angiography revealed a distal M2 segment branch of occlusion of the left MCA. So a distal M2 occlusion can easily propagate proximally to the MCA bifurcation, converting a minor stroke into a catastrophic stroke, hemispheric stroke. And this occurs in up to 30% of patients who are left untreated. Next slide. So in this case also, our clinical decision was to thrombolize immediately, because a distal occlusion with disabling cortical findings warrant thrombolysis intervention regardless of the low NHS score. And also the AHA ASA guidelines, they state that the thrombolysis is indicated for low NHS score 0 to 5 if the deficits are deemed functionally disabling. So always define disability from the patient's functional perspective, not on the basis of any other numerical threshold. Some examples of disabling deficits include complete hemianopia, severe aphasia, visual or sensory neglect, or motor deficits affecting the manual manipulation. Let's go to the next slide. So now the third and the last case scenario. Here the patient is on active anticoagulation. She is a 72-year-old female patient who is with non-valvular atrial fibrillation, and she arrived at the emergency with severe acute onset left-sided hemiplegia, left facial droop and neglect. On examination, the baseline NHS score was 18, and the family members confirmed that she takes apixaban 5 milligram twice a day, and the last dose was taken 6 hours ago. So in this patient, we are dealing with a severe stroke due to the NHS score of 18, and there is a therapeutic contraindication because active dose of apixaban taken 6 hours ago means the drug levels are at or near the peak therapeutic concentration. Next slide. So there is absolute contraindication of thrombolysis because the direct oral anticoagulant was administered within 48 hours, and unless there is a specific calibrated lab assay that is normal. But in case of this assay, it takes time, minimum of 60 to 90 minutes, and every minute, you know, around 2 million brain cells are lost. Now, in this patient, if the patient was taking dabigatran, in that case, there was an option of reversal with idarosizumab or Praxbind because it permits safe thrombolysis immediately. So in this case, waiting for the lab reports is a losing strategy unless the center has very fast facility of the assays. Next slide. Can I go to the next slide?
Yeah.
So to directly because physically removes the thrombus and it circumvents the systemic anticoagulation bleeding hazards. What is the trial evidence? Based on the MR-Clean and the Hermes meta-analysis, it has showed that the endovascular therapy remains highly effective for large vessel occlusions in patients on chronic oral anticoagulants with excellent recanalization rates. And this direct endovascular treatment avoids the major systemic intracerebral hemorrhage risk associated with the giving thrombolytic agents on the top of oral anticoagulants. So now the topic of the trade is that what agent to give, whether alteplase or tenecteplase. So alteplase is the historic gold standard and it was the only option that was available earlier, but it requires a 1 hour continuous infusion setup via an infusion pump, and there is a risk of transport complications or pump failure. Whereas in the case of tenecteplase, there is features of high fibrin specificity, and so it targets the clot directly and minimizing systemic consumption of the circulating fibrinogen. It has a prolonged half-life which facilitates administration as a rapid single bolus dose over 5 to 10 minutes. And it has a plasminogen activator inhibitor 1 resistance which resists the breakdown by plasminogen inhibitor and improving the success rate against dense clots. So in case of tenecteplase, there is a mutation at 3 sites which achieves 80 times greater fibrin specificity and 80 times greater resistance to the plasminogen activator inhibitor 1. Next slide. So what trials are there? Some landmark trials that we can cite as evidence is the extent IA-TNK trial, which compared the tenecteplase 0.25 milligram per kg with alteplase 0.9 milligram per kg. And here tenecteplase demonstrated significantly higher arterial reperfusion rates, 22% versus 10%, and also improved functional recovery at 90 days. Whereas the ACT trial, it was a massive trial of 1600 patients, and they evaluated broad unselected acute ischemic stroke patients. Here also tenecteplase proved non-inferior to alteplase for excellence functional outcome. So we can say that tenecteplase is a safe, clinically equivalent or superior and much easier in operation than alteplase across all thrombolysis eligible patients. Next slide. So we should remember the dosing and the protocol. In case of alteplase, it is 0.9 milligram per kg, and the maximum dose is 90 milligram, 10% as bolus over 1 minute and 90% over the 60 minutes. The problems is the high risk of infusion pump errors, transport delay, and line clotting. Whether in case of tenecteplase, the dose is 0.2 milligram per kg in India, and globally it is 0.25 milligram per kg, maximum at 25 milligram, and a single rapid bolus over 5 to 10 seconds. So there is no need of infusion pump and simplified transfer of the patient to the cath lab. Here you should remember that the dose capping or maximum dose is not negotiable, because if the weight of a person is more than 100 kg also, we cannot give a higher dose, because that will increase the bleeding risk. Next slide. Here is the last case scenario. If a patient from a peripheral hospital contacts you and regarding acute right MC occlusion, and they intend to start the thrombolysis from their hospital only and transfer the patient to your hospital. So in this case, if both alteplase and tenecteplase are available, then which should you prefer? So here the choice is tenecteplase, because as you know, there is no need of infusion pump, and that will help in the immediate transfer and by the ambulance, and there is a higher likelihood of clot dissolution during the transfer. So that is known as the drip and ship protocol. It completely eliminates the pump management and helps in the easy transit of the patient. Next slide. So just one slide about the complication. If there is a post thrombolysis bleeding, in that case, if a patient who is undergoing thrombolysis develops a severe headache or a projectile vomiting or an acute drop in GCS, we should immediately stop the thrombolysis, and we should proceed for an urgent CT scan to identify any symptomatic intracerebral hemorrhage. We should send emergency lab reports, and we should give antidotes, that is cryoprecipitate, and if it is not available, we can start with a tranexamic acid 1 gram. Next slide. If there is another rare complication of perioral angioedema after the thrombolysis, we should proceed with the airway management. First step is we should stop the infusion immediately. The second step is we should administer IV methylprednisolone, and the third step we should give subcutaneous adrenaline if there is airway stridor. Next slide. So in summary, if there is these 4 clinical scenarios, first one, if the patient is of unknown time of onset, we should proceed with the MRI stroke protocol to see if there is any flare or diffusion mismatch, and we should treat based on this wake up trial. The second case scenario, if the extended window of 4.5 to 9 hours, we should proceed with the perfusion study to see perfusion mismatch, and we should treat if there is a small core or a large penumbra mismatch as per the extent trial. The next scenario is of a low NIHSS score deficit 0 to 5. Here also we should do a clinical assessment to see if there is any disabling symptoms, and we should proceed with the CT angiography to see if there is any distal occlusion. And the last scenario, if the patient is on active direct oral anticoagulant, here we can skip the thrombolysis and proceed directly to mechanical thrombectomy if there is large vessel occlusion in the CT angiography. Thank you for your patient hearing.
Yeah, thank you, Dr. Joydeep, for your excellent cases. So, in your first case, like wake up stroke, whether there was any large vessel occlusion, because you said like hemiplegia and aphasia, so probably there may be a large vessel occlusion. So, any CTA was done?
In the first case,
Yeah, wake up stroke where you thrombolized based on a DWI flare mismatch.
Yes, yes. Yes.
Okay, so there was large vessel occlusion also. So after thrombolysis, whether that recanalized or patient was taken to like cath lab?
No, no, the patient was, no, actually, what I have to tell is that due to the time constraints, I have made this case scenarios
Okay.
instead of this.
Okay, okay. So understand.
So for a discussion purpose.
Okay, okay, good. So yes, what you told is exactly true. Like wake up stroke, we usually follow the same protocol. Like whether it's wake up stroke or unknown time, it's better to do MRI because that gives you parenchymal picture and whether there is any flare changes or not, because it takes some 4 to 6 hours to develop flare changes usually. Based on that, we do a lot of IV thrombolysis. Second case, what you said, like there was a thrombolysis in minor stroke or rapidly improving symptoms. So yes, correct, because disabling deficit, we, as you told, like aphasia or field defect or wrist drop, and it again depends on the what job patient is doing. It again
Yes,
depends on that disabling, because as you said, like for an accountant, even minor deficit or even gripping problem can be severe. So
yes,
yes, in minor stroke, depending on the like what the job patient is doing, usually we go ahead with IV thrombolysis because again, in such cases, risk of hemorrhage is also very less because the area involved is very less. So the chances of reperfusion hemorrhage are more, particularly in larger stroke, because there is a large area involved and there is a, and that may be catastrophic. Even in small cases, I will say that even if you thrombolize and even if it's bleed, there is not much catastrophic situation. Again, particularly in minor stroke, whether it is disabling or non-disabling, if there is a large vessel occlusion, we always tell to thrombolize them. Like for example, if recently we had a patient M1 occlusion and patient came with a just minor mild dysarthria. Initially, she had facial droop also, but with time it improved and there was little bit dysarthria, minimal dysarthria. But because as you said, particularly with large vessel occlusion, whether it is disabling or non-disabling, it can anytime propagate and anytime can present to you with a larger symptoms like drop in increase in NIHS score and drop in sensorium. So that's why we advise, like if you get a minor stroke, even non-disabling with a large vessel occlusion, always go ahead with IV thrombolysis. And next, EVT depends on the symptoms. Like we usually in such situations, we watch the patients over 24 to 72 hours, do at the workup, because we have seen that this patient can deteriorate anytime. And if they deteriorate, we reset the clock and take them to cath lab. So third
and
case.
one point I'd like to mention that because in this type of patients, usually the patients come in the emergency, and if we rely on the emergency doctor only,
Yes, yes, very difficult, very difficult.
very
Until
difficult that
unless you are present there,
yes,
probably this case will be missed. So until unless your RMO who is like doing a stroke on call with you are not available or you are not available, that these cases are usually missed. I know.
yes.
And third cases, you rightly said that in a patient with a like known AFib on DOAC, if not on like particularly dabigatran, because itazumab is only available, but again, it's not available in each center.
Yes,
And
yes.
it takes some times if you order and it comes from like, it takes around 1 hour. But even if it's available in center, you can, yes, you can reverse it and can thrombolize. Otherwise, if there is a large vessel occlusion, we always tell them don't waste time and go ahead with this EVT. So, because andexanet alpha is available outside of India, but not in India. So in your case, anyway, we could not reverse it. I think our moderators, anything want to share regarding Joydeep cases? Biswajit?
This first case, actually, vessel study, I think it is done, but because of short
Yeah,
time,
because
there's
he
no
have put
present.
just a case scenario for understanding. So that's
Yes,
why
yes.
probably.
Actually, in that cases, we
Yeah,
after
yeah.
thrombolysis, then immediately, if there is any large LVO, so we
We
take
definitely we
that.
take these patients to cath lab.
And very important, this is actually a few months back, actually, third case, similar type of case we got. This patient having hemiplegia, and he's on NOAC. So he's on NOAC, large occlusion. Immediately we took the patient to cath lab, and there was a clot actually, and because of cardioembolic stroke is very easily it can
Yeah,
be removed with thrombosuction.
because these are usually soft clot.
These are the soft clot.
Until and unless there is a ongoing atherosclerotic
Yeah.
process.
And patient
Sometimes there is
improved.
a, yes.
Patient also improved. And after the 1 or 2 days, actually, we have to, that is post-stroke, we have to evaluate that Eliquis, because patient was on Eliquis, but stroke has developed. So is it Eliquis failure or it is some other mechanism? These things
Definitely.
we have to evaluate. And sometimes what happens, patient, sometimes aged patient takes the medicine, whether they are taking properly or not. This is also very question. One patient actually, when acute stroke, and they just family member told that he took 6 hours before, but after 12 hours they confirmed that she has not taken for more than 24 hours. So
Yeah.
we have
Yeah,
missed.
sometimes it's difficult because patient
Yeah,
probably is not in a state to tell
yeah.
exactly when he has taken. So we have to rely on family members.
Rely on
Sometimes
family
it's difficult.
members.
It happens with us also, like after like 24-hour pass, then we got to know that actually he's not taking a stop it for
Yeah.
last 48 hours. But because we didn't have that information, so we could not thrombolize. It
So
happens.
history, we have to tell our emergency doctor. Emergency doctor is the main. Actually, if he detect the problem, then he can tell us that yes,
Otherwise,
he has
yeah,
taken. Otherwise,
just to inform that he is taking no act. That's it.
yes. So
Then
don't give any IB. So actually, potential cases we have missed
yes,
because of
understand.
the poor history. So these are the problems, practical problem. Otherwise, that is very good points actually that Dr. Biswas has described. Yes, congratulations.
Thank you.
Good. So we can move ahead with Dr. Babov's case. Babov, you can go ahead and present your case.
Shananda, can I just make a quick couple
Yes,
of
sure.
points?
Sure.
Jaideep, nice cases. Wonderful
Thank you.
presentation, nice cases. Just a quick point for wake-up strokes, as Dr. Paul and Shadananda have also mentioned. Not always do we get CT perfusion guided images for wake-up strokes, and for all of those patients with wake-up strokes, it's a wonderful idea to carry out a DWI-T2 flare mismatch, because that for practical purposes just as good as a diffusion perfusion mismatch. I'm just curious that the first patient had a significantly high NIHS. Did you get a CT angiogram done? Because you did not mention that. Or I missed it. I'm not sure if you
No. Actually,
mentioned
Dr.
it.
Jaideep already we discussed it earlier. He said like he just made the case
I just
for
set up this case
understanding,
for discussion.
for presentation, for
Okay,
discussion.
okay. And the second point that I was trying to think of again is the second case that you were mentioning, where there was a M2 occlusion. Post thrombolysis, if this was at your center, did you think of a possible catheter guided procedure? Because that is a patient who's going to likely benefit from a catheter guided procedure at some point, because there was
Um,
a distal embolism causing the stroke.
Actually, currently it is not available in my
Not
center.
available in your center.
So we explain the patient that this facility is not available.
Hmm. Because that is a patient who might come back with a larger, more debilitating stroke in the future.
Yes, yes,
Probably
of course.
would benefit.
Yeah.
And as you rightly mentioned, that any
Yes.
as you rightly mentioned, any patient who's we should not be guided by the NIHSS only, because, as you said, even the minorest of disabilities is a disability, and it's a disability which lasts for an entire lifetime. And it's been found that most studies have actually suggested that even the smallest of strokes, minor strokes, or even high-grade TIAs, high-grade TIAs, of course, you can't thrombolize, but everything else for minor strokes, if you do not thrombolize, the eventual outcome is poorer. So it was a good decision again. Wonderful cases. Thank you.
Regarding
Thank
the
you.
medium vessel occlusion, there is mechanical thrombectomy in medium. Still, it is in the that is category. This is not the there is a class 1 evidence. This is the class 2 evidence, and this should be taken into case to case basis, and depends on the available center expertise and this all these things actually. Because if some complication develops, and because there is a minor stroke, very minor, so if any complication then it is very difficult to that is establish the
Yes.
oil.
Vishwajit, I was asking, would you think this patient is amenable to a stenting later because it's an M2? Not for a mechanical thrombectomy, but what about a stenting?
Yeah, stenting, carotid stenting, if there is any symptomatic stenosis. Symptomatic means that is
But
if it's more than 50%. More than
in this case, because this case
Yeah.
there is a
Are you
significant
asking about
occlusion.
carotid stenting or M2 stenting?
M2.
no, no,
M2.
no.
M2 static is strictly no. Still,
No.
there is a clear-cut guideline about when to, even like we usually in our center, we only do stenting particularly when we are like forced, or we have like recurrent stroke despite like treating everything, like we are giving dual antiplatelet, we are treating blood pressure, we ruled out other mechanism of stroke. So only for M1, I don't think people usually go with M2 stenting. I don't know whether whether you have
Interestingly,
any
Shadananda,
experience.
Yeah.
interestingly, I've just got a patient who's had a stroke 6 months ago on dual antiplatelets. Yes, for 6 months he's on dual antiplatelets. CT angiogram suggested a tight stenosis at M2. He's had a recurrence of stroke. He's been very compliant, but he's had a recurrence of stroke. So in this case, would you probably think of a
Usually,
stenting?
I have even never has seen any M2 stenting yet. So I don't know, in literature probably it will be there. I don't know, Biswajit has experience, like whether you have seen M2 stenting.
No, ekdam completely. This is clear cut. This is ICAD. If recurrent stroke and failed with the best medical treatment. So best medical treatment means that we have to give the highest dose of that is double antiplatelet like that, and we have to wait for 3 months. So
So
within the 3 months, if there is any recurrence of the stroke, then we can consider.
Bishopji, that the person has been on dual antiplatelets, clopidogrel and aspirin for 6 months, and now there is a recurrence of stroke. So would you advocate going up to ticagrelor? Maybe
In that case, actually, we can consider. We can
with an
consider.
M2 stenosis.
Yeah. We can consider. Now, thing is that in the Asian scenario, clopidogrel resistance is almost
Resistance.
50%.
Quite high.
Clopidogrel resistance.
Hmm.
So before thinking for stenting, we have to change. That is ticagrelor plus
Ticagrelor.
aspirin combination.
But in such cases, how many days do you need to put the patient on ticagrelor?
Usually for M2 tight stenosis or like intracranial atherosclerotic disease. So usually if you say like guideline says like at least for 3 months, but
3
practice
months.
is like we go much
Lifelong.
beyond that.
Lifelong,
So I
practically.
will say that yes, people will see if you're in literature, you will see dual antiplatelet for 3 months, but in practice, most of the like stroke specialists or neurologists continue this beyond guideline, beyond this 3 months until unless there is a clear-cut high risk of bleed, like where there's very high risk of bleed. Otherwise, usually in intracranial atherosclerotic disease or large vessel extracranial atherosclerosis, we continue dual antiplatelet, sometimes 6 months, 9 months, or even 1 year or beyond that also.
In that ICAT case, if there is an M2 stenosis, we have to repeat the DSA. Best is the DSA, if not available, the CT angio.
DSA was done. Following up a CT angio.
Yeah, to see the collaterals. So in that case, I have seen that there is a small infarct, low flow, but within 3 months to 6 months, there was a good flow established from the side by side. So, so if there is any good collaterals, so we are very much satisfied.
So the thing was, there was a DSA done 6 months ago, which showed the tight M2 stenosis. I have not done a DSA. I have asked for a DSA to be done. The only question is, he was on dual antibiotic, as you're right, we could probably switch to ticagrelor and aspirin. And that's what I've done. I'm just curious as to whether this patient would benefit for a very long-term use of ticagrelor and aspirin, because even with aspirin and clopidogrel, he's had a second stroke. And he's quite elderly, in his mid-70s. So there's always a risk of bleeding in these patients.
Yeah. Sometimes risk of bleeding is also there. Sometimes we get that patient may have GI bleed, may have hematuria like that. So yes, it's
But
sometimes
if he is having a
difficult.
recurrent stroke, is the mechanism of stroke the same on the same side? I mean, the mechanism is same.
Second, I've got a web cardio done for 7 days. That's absolutely normal.
Okay.
So if you are getting same stroke, so probably that is the culprit. Anyway, I think we have already 10 minutes left. So Vaibhav, you can go ahead with your case.
Okay, sir. So good evening, everyone, and thank you, moderators, for this kind introduction, and thank you to the organizers for allowing me to present the cases. Sir, I have 2 cases here. What I will do is I'll stop after each case and I'll go for the discussion, because I think it is better to have a discussion in midway than at the end, if allowed, sir.
Sure.
Okay, sir. So I hope my slides are visible.
Yes, it is visible.
Yeah, thank you. So I had this 50-year-old female hypertensive non-diabetic patient who presented with acute onset right-sided hemiplegia, dysarthria, facial droop, and aphasia around 8:30 a.m. early morning. She landed to the emergency around 11:30. During the presentation, her NIHS was around 22. So very high NIHS. She's drowsy, intermittently responding to commands, and gaze was deviated to the left side, right hemiparesis, aphasic, and video. I'll show the video. So I have 2 videos here. This is the video of the case that I was talking about. So we've already mentioned that it's always good to have video from the emergency resident so that you can judge what is actually happening.
Right power 1 out of 5.
So you can see the gaze is kind of deviated to the right side. She's moving her left side. She's not moving her right side. And she's aphasic.
Right.
And we can see that there is a facial asymmetry also. Okay. I'll show this case also. So this is aphasia, right-sided, dominant lobe infarction that we are talking about. And this is another case.
Chulam? Huh? Dan hath. Donata chulam?
If I'm doing the test simultaneously, she's not able to understand which hand I am touching.
Donata chuechi? Donata? Ekon konata chuechi? Ekon konta chuechi? Dan hath.
You can see that she's came with a left-sided weakness, but is not able to make out which side is the right and the left.
Donata chulam?
So for the first case, when we did the CT on admission, the CT was fine, but it was showing a dense MCA sign. So we went with the thrombolysis, and after the thrombolysis, we put up for a CT angio. So when we did the CT angio, you can see that there is a M1 occlusion. And just because it was done post thrombolysis, so I think some amount of contrast is also percolating there. So we put up the patient for thrombectomy. And so I think everyone would agree here that we need to go for thrombectomy now. Patient is in window period, 3 hours time. We have done the thrombolysis. So as we did the thrombectomy, IVT also done and mechanical thrombectomy was done, and we achieved a good circulation. And the door to cath lab time, you can say, was approximately around 1 hour. So this goes actually with the recommendations that we have, that if you are having if you are having an acute ischemic stroke well within the window period, so 1080 plays is now being preferred over alteplase. And when we are doing a concomitant IVT with a mechanical thrombectomy, for those who are eligible for both, it is reasonable to go for, give the IVT is safe, and then you can go for the thrombectomy. But what really happened to the patient the next day when we repeated the CT scan? So as you can see, when we repeated the CT scan, this is on day 1 and this is on day 3. So what you can see that the patient has developed a left basal ganglia infarct, and there is also hemorrhagic transformation. Concomitant with that, what we are having is she's having a tachybrady syndrome, she's having an atrial fibrillation, 6 sinus syndrome going on, multiple history of syncope in the past, and she has also developed aspiration pneumonia, and she's presently on antibiotics. So we have not yet discharged the patient till now, still under treatment. So now the question is, she needs an anticoagulation, whether she needs a pacemaker, and she needs actually stabilization and to come out of her this aspiration thing. So going everything with the book that we could go off, but she ultimately developed this complication of hemorrhage. Sir, your take on all on this case, sir?
So yes, Vaibhav, you have very good case, and like you rightly did the IVT and then like EVT. Again, remember that alone IVT and EVT can lead to reperfusion bleed, and if put together, there is a little bit higher chance of reperfusion bleed. But if you see the CT scan, after doing EVT, you saved a lot of cortical area. You can see only hemorrhage in the basal ganglia region. Okay. And the reason why this basal ganglia area risk of like hemorrhagic reperfusion bleed is more because these are supplied by indward arteries. So that's why particularly, even if you particularly do IV thrombolysis or in endovascular thrombectomy, you can see that you have saved a lot of cortical area. So that's why you probably saved us a big right hemiplegia and aphasia. Yes, this hemorrhagic conversion can happen, and we are okay with it. So, like we explained family that yes, there might be reperfusion bleed, and it will take time. So usually in such cases, if because you already said that there was a atrial fibrillation going on, so we know that it was a cardioembolic stroke. And in cardioembolic stroke, without doing anything, like even if you don't do anything, chance of a spontaneous hemorrhagic conversion of an infarct is up to 20 to 25%. So it's not like that you just do a IVT or EVT, then only reperfusion bleed happens. It can happen without that also. We have seen that patient comes with a beyond window period and there is a spontaneous hemorrhagic transformation. So, and in such cases regarding anticoagulation, usually we have to wait till a resolution of hemorrhage. Particularly, it takes around anything near like 3 weeks, probably 2 to 3 weeks, and then we do serial CT and then start anticoagulation. And regarding the pacemaker, I think it's the cardiology call when what they interpret about this tachybrady syndrome, whether the patient can sustain this for a longer period and there is an urgent need of like pacemaker or not. I think best way to first stabilize patient, treat aspiration pneumonia, treat and increase intracranial pressure, wait, do serial CT. Once there is a resolution of like hematoma, you can then restart anticoagulation.
Right, sir. And sir, as I just said, I had shared the second video also. The second video is of a different case. I have not uploaded the CT scan. That patient had a left-sided hemiparesis, right side stroke within window period, thrombolized. On
Mhm.
CT angio, she showed right M2 occlusion. Now, since we're
Mhm.
discussing too much about the M2 here, so I just wanted to have an opinion that now we are going for thrombectomy for MEVO. So
Yes.
is there any difference that we should go for in deciding whether we are thinking of the dominant lobe MEVO or we are going for the non-dominant lobe MEVO? So whether the management changes or should we go for actually, my question would be, should we go for the thrombectomy in MEVO occlusions or not?
Biswajit, you want to share?
Uh, yes, definitely we should go for that. In second case, you have not described that patient came within window period or it is not.
So I just shared the video that one is of the dominant side and of the non-dominant side. I'll just give the history. The patient for the second video which I had shared,
Yeah.
patient had a left-sided weakness. NHS was around 12
Mm.
and she was within the window period
Yes.
of, she came within the window period of 2 hours. We
Okay.
first thrombolized the patient and then we took her for the CT angio. As we did the CT angio, we could see that there was a right M2 occlusion.
Occlusion with the what about the collaterals?
Good collaterals.
Yes, good collaterals. But I think we should go with that medial basal occlusion. Yes, in that cases.
Yeah, because I think there was a INHA score was high because that it means
Yes.
that that was dominant M2.
Uh,
So if it is a non-dominant M2, sometimes then you have to decide, like talking with family, explain
mm,
the risk, benefit, and then because every case is different, you cannot like say anything about you can say a particular thing about a single case only, but not every M2 is same.
mm,
So dominant M2, yes, there is a clear-cut guideline you have to go. Now non-dominant M2 or distal M2 occlusion, M3, all depends on the like how much deficit is there and what you will achieve, what is the expertise, whether people have experience of doing that or not. There are so many things
mm.
because definitely you don't want to do any harm to patient. So
Yes.
if you are very sure that yes, this patient can benefit and you can still save a larger area, then obviously you can go ahead. I think
Yes. Right.
that should be our
You have
goal.
right. Yes. Now I am thinking about that first case actually. That first case, the patient came with aphasia, dense hemiplegia. So probably this is the left MCA. It
Yes,
is
yes.
left
He
MCA.
already showed that there is a
Yes.
hyperdense MCA
And
sign.
and I'm thinking about the CT NGO. There is also good collaterals.
Hmm.
Yes, that collaterals. So because of that only, uh, there is a cortex is spared.
Yes, yes, yes. Because you
And
immediately
why there
recanalize,
is
there was
and the infarct is mainly in the that is
basal ganglia
perforator.
area,
Yeah, perforators
perforators.
affected. So by this time the clot removed already, some perforators
Yes, some part of the
already
area
damaged.
already damaged. Yes.
Supply area is damaged. So that's why and it is a cardioembolic and over that we have given IV thrombolysis.
Thrombolysis. Yeah,
So
so
so these two factors added this bleed. That is this bleed. So that patient will have dense hemiplegia, definitely dense hemiplegia. I think power will be in the after bleed, I think 0 or 1. And
yeah, it
she
will take time, but that patient will improve gradually.
and the speech will also be affected because it is in the dominant hemisphere. So
Absolutely.
overall prognosis is bad, and you have told that aspiration. We have seen that in if the stroke in the dominant hemisphere, there is a patient is a bad candidate for physiotherapy because patient cannot follow this physiotherapy instruction and high chances of aspiration like that actually.
True.
You have done best because you have told that the door to need groin puncture time is around 1 hour. So it is excellent. It is excellent. Actually, congratulations to you and your team. But unfortunate, this is very unfortunate
Absolutely.
possibility of it.
Yeah.
So I have
So
one more case to
yes,
present.
yes, you can go ahead with another case.
So this was a case of 82-year-old male with hypertension, non-diabetic, who presented with acute onset right hemiplegia. He's aphasic and was unresponsive. He stays alone. And he was last seen normal by his daughter at around 1 p.m. afternoon. And then p.m. He was drowsy and gait was deviated to the left side, right hemiparesis, aphasic. Also, post PPM status and NIHS was close to 22. I'll quickly go through the imaging. So this is the baseline imaging that we have. Involved the basal ganglia, insula, external capsule. We can see the lens MCA here. If we go through the angio here, so there is cutoff from the M1 and also there is tandem occlusion. We can see the
Yes, yes.
ICA so
I see occlusion.
occluded in the neck.
And collateral, there is, I think, yes, you need to do a triple phase CT, otherwise it is difficult to tell. But from the first phase of CT scan, at least we can say that collateral is not good.
Not good.
But yes, sometimes it can mislead you. First phase of CT scan. If you do the delayed phase, then you can actually tell actually. Anyway, I think you already showed that CT scan already showing some early ischemic changes. So we can see and like insula, we can see perisylvian area or M2, M4. So that's why I think your aspect is poor. Yeah, but this patient reached within window, I think one and
Sir, he
like
was
3
last seen normal 1 o'clock in the afternoon a day prior. He has come
day
to the
prior.
emergency 3:30 p.m. So nobody knows when the event actually took place. He's
Okay.
having a pacemaker. Pacemaker status is also
Yeah, so difficult to do. So we cannot do MRI. So we don't have idea about like DWI flare mismatch, whether there is not. Yes, so I think I will prefer in this case, I will go ahead with endovascular thrombectomy rather than IV thrombolysis, because first thing, I don't know the onset time. Second is like already we can see early ischemic changes. Like you can see a lot of ischemic changes. And at the same time, like if we don't do anything, then probably this patient will end up with a very large stroke. We will require decompressive hemicromectomy. So I will particularly go ahead with EVT alone rather than doing IV thrombolysis than EVT, because I don't have like that imaging guidance, like whether I can see that this patient has onset within 4.5 hours.
True.
Yes. In this case, actually, if CT perfusion is available, then it can give some guide. And if it is not available and the party is ready, then yes, definitely we can try with mechanical thrombectomy maybe with poor prognosis, because
Yes,
the
in
impact is
such
very
cases,
large.
you have to clearly explain that if we don't do anything, so
Yes.
definitely this patient is going to end up in a ventilator. We don't know whether he will survive or not. He will require probably, because it has a tandem occlusion. So probably gradually ACA will also like end up. So I think we definitely in such cases, particularly if elderly, we can clearly tell the prognosis. And
Yes.
if they are willing, I think then we can go ahead with endovascular thrombectomy.
Yes. With high chances of bleed.
Yes, yeah, definitely. A reperfusion bleed again in this case is also high, because you can see already some early ischemic changes. So
Isn't age actually a cutoff here? He's 82.
no.
He's
Age is
he's
still
Not
not a
anymore.
cutoff. But yes, this is a not a good case for endovascular thrombectomy, because poor aspects is there. NH is very high, elderly, uh, tandem occlusion. So we don't know, like, because in this age, when you negotiate how whether you will able to reach that area or not. So that definitely this is not a good case. It's all depends on if you talk with the family and tell the scenario. And if we want to do anything, then yes, we can do EVT. But again, definitely, as Biswajit said, we have to tell the prognosis. We don't know, even after doing, probably he will end up with a large stroke, because already we can see ischemic changes. You will take this patient to cath lab. Again, it will take another 45 minutes to 1 hour. because family, you will talk with family. So there are so many things. Now you have seen that how much time it takes. So family will decide. So by the time you will do groin puncture and remove, probably this will increase further. So definitely in such cases, you have to get clear cut idea from family what they want and whether they are ready to accept. Like we have tried everything, but it still land up with a large stroke, and probably this patient will again, despite doing EVT, will require uh, decompressive hemiconectomy if family agrees. In particularly large such cases at this age with PPM, I only tell family not to go ahead with a decompressive hemiconectomy. But again, it depends on the family's decision.
Family's call.
And technical problem is during mechanical thrombectomy.
Yes, yes.
Actually, there is the carotid. There is a carotid occlusion and with bad narrowing and calcified plaque, I think. So
Yes.
if there is a so there is a two problem. One is in the ICA origin, and second is the intracranial part. So the procedure time will be high, and patient may require, that is stenting also in the
And
procedure.
cost, you add cost on
And the
top of that.
cost.
One is the
So
cost,
that is the
and there
more
is because
important
of
thing.
the
So
there is a time, there is a more time required, and there's a with more complication.
yes,
More
yes.
complication, and ultimately the
Ultimately
patient's
you will
family is
lose
always
patient with expending so much money. That's the always case. But yes, you have to give them option, because
Yes.
otherwise what happens now, if you don't give at least option, they will go with CT scan to anyone, and they will say why they have not done this, they could have saved. So I have burnt my finger with such cases. So nowadays I tell them like what can happen and what are the chances. If they are willing to spend and accept all this thing, then go ahead with the EVT.
Yes.
true.
So what you did in this case, like what family whether agreed or like I wanted to know, like
So I was very luckier. Family is a cash patient. They denied everything.
good, good.
You have saved yourself.
I was just wondering what to tell them. So I just asked them that, what is your budget? So I got the answer. I did not have to speak much.
Understand.
So that's all with my cases here. Thank you, sir.
Good, good. Very interesting cases and clinical dilemma, definitely with both the cases.
Uh,
Uh, I think whether there is any questions from audience or
Dr. Shrutal, do we have any questions?
Question.
So there is no question, Dr. Shrutal?
No questions.
Okay. So sir, as it is, they were supposed to type. So that's the
yeah.
case.
Anyway, I think we have discussed a lot about every
Yes.
case, so probably they
Yes.
got their answers. So I think it was a very interactive case discussion with all very good cases from Jaydeep and very good cases from Vaibhav. So we have clinical dilemma, different scenarios, and I think like all the participants got some idea, because they will in real time they will get similar cases. So how to go ahead with similar cases. I think if because already we passed 9:30, so if there is no question, we can close the session.
KG, you can propose the vote of thanks.
Yes, sir. No,
Thank
sir,
you.
thank you very much. I start thanking by from Genova side, Dr. Sadanand Day for being a great help with respect to the very good discussion with three cases each with our esteemed speaker, Dr. Joydeep and Dr. Vaibhav. And we have got a very good moderation from Dr. Biswajit as well as Dr. Anandam Ghosh. So thank you very much, sir. Look forward to see you again with some more interesting cases where I think our audience also can learn a lot out of the discussion which we might have. Thank you once again, sir.
Thank
Have a
Thank you.
good night.
Thank you, everybody. Good night.
Thank you, sir. Vaibhav sir, although
Thank
you
you,
are good, but
everyone.
thank you very much.
Good night. Good night.
Thank you.